Welcome to the deep dive. Today we are opening up a First Aid and CPR ED provider handbook to do, well, a really comprehensive immersion into the protocols of emergency care.
Yeah, and this is for you, the learner. Whether you're a med student, a young professional, or just someone who wants to be truly prepared, we're not just talking about general awareness.
No.
We want to get into the why, the technical details you need to be a competent provider when every single second counts.
I like that distinction.
Yeah.
Moving from just awareness to actual precision. Okay, so let's start at the very beginning. The handbook defines first aid as, the immediate care you give someone. But before you do anything, what's the first non-negotiable step?
It's actually two things at once. Recognizing there's a problem and immediately activating EMS, calling 911 here in the U.S.,
Okay.
and that dispatcher on the other end. They're your first line of support. They're trained to talk you through CPR, AED use, everything, until help is physically there. Never, ever assume someone else has already called.
And before you even get to the person, the handbook is really, really clear on safety. The first question you have to ask yourself.
Is the scene safe?
Yeah.
You cannot help anyone if you become another injured person. It's that simple.
Right.
Look for traffic, for downed power lines, any kind of hazard. The priority might actually be moving the person out of danger if you can do it safely.
So once you've established safety, you get into consent. And this idea of implied consent seems really critical for anyone training in this.
It's huge. I mean, first you introduce yourself, say you're trained, and ask, can I help you? That's explicit consent.
Simple enough.
But if they're confused or unconscious or just so badly hurt they can't answer, well, the law assumes they'd want you to help. That's implied consent. It lets us act without a fatal delay.
And before you make contact, PPE, universal precautions are mandatory.
Absolutely. Always assume there's a risk of exposure to bodily fluids. So gloves are a must. Maybe eye protection if they're splashing.
And for breathing.
A pocket mask. It's essential. And when it comes to hand washing afterward, the handbook is specific. It's not just a quick rinse.
No.
It's vigorous rubbing with soap for at least 20 seconds. All surfaces. It's the friction that really does the work.
Okay, so before we jump into the emergencies themselves, what about the first aid kit? What are the key things people might overlook?
A breathing barrier for sure.
Yeah.
Plenty of sterile gauze, antiseptic wipes, and honestly, a good up-to-date first aid guide right there in the kit. You need the tools ready to go.
Okay, so safety's established, we're prepared. Now let's get into the high-stakes stuff. First up, breathing issues. What are the sounds we should be listening for?
You're listening for wheezing, which usually points to something like asthma, sort of in the lower airways.
Okay.
Then there's this high-pitched sound when they breathe in. It's called stridor. That suggests a serious blockage higher up in the throat. A huge red flag.
And for an asthma attack, the book details a very specific inhaler technique, especially with a spacer.
Yes. The spacer is key. It gets the medicine deep into the lungs. So you shake the canister, put it in the spacer, have them breathe all the way out.
Okay.
Then they breathe in slowly and deeply as they press the canister. And they have to hold that breath for about 10 seconds. If that doesn't work after a couple of tries, it's time to call 911.
And then things can escalate very fast. Let's talk about anaphylaxis, a life-threatening allergic reaction.
This is where epinephrine is the only answer. It's the one thing that can reverse that dangerous airway swelling.
And you use it immediately, right?
At first sign of a severe reaction, you don't wait. You just take off the safety cap, press it hard into the outer thigh, it even works through clothes, and hold it there for a full 10 seconds until you feel or hear that click.
What's the critical next step?
Note the time. You have to note the time you gave the injection and call 911. Epinephrine wears off, and the symptoms can come right back. The ER team needs to know that timing.
All right, shifting gears to the heart. Cardiac emergencies. The book's mantra is time is muscle.
Because every minute of delay means more heart tissue is dying. It's that critical.
But the signs aren't always that classic, Hollywood-style chest clutching.
Not at all. And this is so important. Women, older adults, and people with diabetes, they might just have extreme fatigue or be really nauseous or suddenly short of breath. No chest pain at all. You have to have a high index of suspicion.
And if they're conscious and you don't suspect a stroke, the book says to give aspirin.
Yes, 2 to 4 chewable baby aspirins or 1 adult aspirin. But it has to be non-enteric coated.
Why is that?
Because an enteric coating is designed to stop it from dissolving in the stomach, which is the exact opposite of what you want. You need it to be chewed for rapid absorption. And critically, they need an ambulance. Do not let them drive to the hospital.
Okay, let's move to the brain. Neurological emergencies like stroke. Here the mantra is time is brain.
Right. And if you see the signs, facial droop, slurred speech, one-sided weakness, the single most important piece of information you can provide is the exact time the symptoms started.
That's what determines treatment.
It determines if they're eligible for the clot-busting drugs that can reverse the stroke. It's everything.
What about seizures? The handbook has some very clear don'ts.
Yes. Your main job is just to keep them safe. Move furniture away, put something soft under their head. The big things not to do, don't restrain them, and absolutely do not put anything in their mouth.
You could injure them?
You could break their teeth, their jaw, or get bitten yourself. As soon as the seizure stops, you just roll them onto their side.
And what about low blood sugar in diabetics? It can look a lot like a stroke or seizure.
It can. Agitation, confusion, weakness. If they are awake and can swallow safely, give them sugar, juice, a non-diet soda, glucose tablets.
But there's a big if there.
A huge if. If they can't sit up and swallow, you give them nothing by mouth. You risk choking or aspiration, you just call 911.
Okay, that covers the big internal emergencies. Let's pivot to trauma, starting with bleeding. Direct pressure is always first, but when do you use a tourniquet?
When direct pressure isn't enough to stop massive life-threatening bleeding, that's the trigger.
And how do you apply it?
About 2 inches above the wound, not over a joint, and you tighten it until the bleeding stops completely. And just like with epinephrine, you have to write down the time. That time of application is vital for the surgeons later.
Now, for something that feels completely wrong, impaled objects, the rule is to leave them in. Why?
It's hard to get your head around, I know. But that object might be plugging a major artery. It's acting like a cork.
So pulling it out
Could lead to an uncontrollable, catastrophic hemorrhage. You just stabilize it with bulky dressings and wait for the pros.
Okay, different kind of trauma. A knocked out tooth. There's a protocol to save it.
Yes. Only handle it by the crown, the white part, not the root. You can rinse it gently, and the best way to transport it is in milk or saline, or even tucked in the person's cheek if they're conscious. Time is of the essence to get to a dentist.
And for any major trauma, like a fall or a car crash, you have to assume a spinal injury.
Always. The #1 priority is to manually stabilize the head and neck. Hold it still. Prevent any bending or twisting. That simple action can be the difference between walking away and permanent paralysis.
What about the protocol for an amputation? You're dealing with two things at once.
You are. First, control the bleeding on the person with direct pressure. Then, you care for the amputated part.
How?
You rinse it gently, wrap it in sterile gauze, put that in a sealed plastic bag, and then put that bag on ice. Never put the part directly on ice. You'll freeze and destroy the tissue. And make sure it goes to the hospital with the person.
Got it. Let's finish trauma with burns. For small burns, what's the immediate care?
Cool water, not ice.
Yeah.
Not freezing cold water, just cool running water. Using ice can actually cause more tissue damage.
A cold injury on top of a burn.
Exactly. After cooling it, you can apply a burn cream and cover it with a dry, non-stick dressing.
And when does a burn become a 911 call?
If it's large, if it's on the face, hands, or genitals, or any kind of electrical injury, all those need immediate medical attention.
Okay, let's move into our next section on environmental hazards. Bites and stings. The source mentions the black widow spider bite can be deceptive.
It really can. The venom can cause severe abdominal muscle cramping. In kids, it can look just like appendicitis. Any systemic symptoms after a bite like severe pain or nausea means a 911 call.
And for a venomous snake bite, what are the big don'ts? All the stuff we see in old movies.
Yeah, forget all of that. Don't cut the wound, don't try to suck the venom out, and do not apply a tourniquet. All of those things can make the local tissue damage much, much worse.
So what do you do?
Call 911, keep the person calm and still, immobilize the limb. That's it.
Now, temperature extremes. How do you tell the difference between heat exhaustion and the much more dangerous heat stroke?
It all comes down to the central nervous system. In heat exhaustion, you're sweaty, dizzy, maybe a little confused. With heat stroke, the brain is directly affected. They might stop sweating, become severely confused, or have a seizure.
And that's a true emergency.
A life-threatening one. You need to start rapid cooling immediately. Spray them with water, fan them, while you're on the phone with 911.
And on the other end of the spectrum, frostbite. What's the right way to rewarm someone?
Gently. Get them inside and rewarm the area in water that's around 104 degrees Fahrenheit. Hot, but not hot enough to burn. And what you must not do is rub the area. The ice crystals in the cells will shred the tissue.
And what about hypothermia, the whole body getting too cold?
Yeah, that's when the core temperature drops. They'll be confused, lethargic, and then as it gets worse, the shivering actually stops. That's a very bad sign.
What's the action plan?
Get them out of any wet clothes, get them dry, cover their head, and wrap them in blankets.
Yeah.
And be ready for CPR, because hypothermia puts a huge strain on the heart.
Okay, final one in this section, poisons and toxins. Besides calling 911, what's the most time-sensitive action, especially for chemicals?
Irrigation, especially for the eyes. If they get an acid or an alkaline chemical in their eyes, you have to flush them with lukewarm water continuously for at least 20 minutes while you wait for the ambulance.
All right, we've arrived at the core of it all. CPR, AEDs, and choking. Let's really nail down the numbers for high-quality adult CPR.
The rate is 100 to 120 compressions per minute. Think of the beat to a song like Staying Alive. The depth needs to be 2 to 2.4 inches, so 5 to 6 centimeters.
That's deep.
It is. You have to push hard. And you're aiming for the lower half of the breastbone, being careful to avoid that little tip at the bottom, the xiphoid process.
Right, because you can damage the liver.
Exactly. And the ratio for a single rescuer is still 30 compressions to 2 breaths. And here's the key a lot of people miss. You have to let the chest fully recoil, come all the way back up between each push.
Why is that so important?
That recoil is what lets the heart fill back up with blood. If you don't allow it, you're basically pumping an empty heart.
Okay, then the AED arrives. Turn it on, put on the pads, but what if the person has a pacemaker?
Good question. You just make sure not to place the AED pad directly on top of the pacemaker bulge. And if they have any medication patches on their chest, you have to take them off and wipe the skin before applying the pads.
What about using it on a child?
If you don't have the smaller pediatric pads, you can use the adult ones. You just have to make sure they don't touch each other. You might have to put one on the front and one on the back.
Okay, this next point feels like maybe the single most important protocol difference for a lone rescuer to know, finding an unresponsive adult versus an unresponsive child.
This is a life-saving distinction. For an adult, a cardiac arrest is usually a heart rhythm problem. So if you're alone, you call 911 first. Then you start CPR.
Call first.
For a child or an infant, the arrest is almost always a breathing problem first. So if you're alone, you do 5 cycles of CPR. That's about 2 minutes before you leave them to call 911. You have to get them oxygen right away.
Care first, then call. That's a huge takeaway. Okay, finally choking. How do you know if it's serious?
If they can cough or talk, it's mild. Let them keep coughing. If they can't make any sound, can't breathe, or have a very weak cough, it's severe and you have to act immediately.
For an adult, that's the Heimlich maneuver, abdominal thrusts. But what if they're pregnant or very large?
Then you switch to chest thrusts. Same spot as CPR compressions, right in the center of the chest.
And for an infant, the whole technique is different.
Completely. You do a series of 5 back slaps between the shoulder blades and then 5 chest thrusts, always keeping their head lower than their body. And if anyone choking becomes unresponsive,
You start CPR.
immediately. And after each set of 30 compressions before you give breaths, you take a quick look in their mouth for the object. But never do a blind finger sweep.
Wow. We have covered a huge amount of ground here, from the tiny details of aspirin chemistry all the way to the precise depth of a chest compression. For anyone learning this, mastering these details is how you stay calm and actually help.
It is. And remember, the source material points to tools like MediCode and CertAlert plus Eller. They're designed to help you keep these certifications up to date and give you instant access to these algorithms when you're under pressure.
So to help all this sink in, we're going to leave you with a focused review question, pulling from that crucial distinction we just covered, critical review question. If you are alone and you find an unresponsive child, what is the specific procedural difference for when you activate EMS compared to finding an unresponsive adult, and what is the underlying reason for that difference?
And for a final thought, we talked a lot about pushing hard and fast in CPR. But why is ensuring complete chest recoil between compressions just as vital for survival? Think about the heart as a pump. Think about the physics of how it fills and how the heart muscle itself gets blood. Understanding that is the key to really high-quality CPR.